Thyroid gland is a bilobed organ in the lower half of anterior neck which is composed of two lateral lobes joined by a thin isthmus. It is located in the anterior region of neck midway between the thyroid cartilage and suprasternal notch. Talking about thyroid histology, thyroid is divided into lobules of 20 to 40 round to oval follicles, each 50 to 500 microns, with a single layer of cuboidal to low columnar epithelium. The lumen contains colloid, which is scalloped and pale in follicles with active secretory activity, densely eosinophilic in inactive follicles, and more flocculent like a clump or tuft of wool, and basophilic in elderly. The stroma contains C cells, which were earlier called as parafollicular cells, but they are actually intrafollicular cells and are derived from the neural crest. These C cells represent 0.1% of the gland and produce calcitonin, are present in the middle and the upper third of lateral lobes. Here I have enlisted the WHO classification of thyroid tumors. The main thyroid tumors of importance are follicular adenoma, hyalonizing trabecular tumor, other encapsulated follicular pattern thyroid tumor, follicular tumors of uncertain malignant potential, well differentiated tumor of uncertain malignant potential, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, papillary thyroid carcinoma, follicular variant of papillary thyroid carcinoma, encapsulated variant of papillary thyroid carcinoma, papillary microcarcinoma, columnar cell variant of papillary thyroid carcinoma, oncocytic variant of papillary thyroid carcinoma, follicular thyroid carcinoma minimally invasive, follicular thyroid carcinoma encapsulated angioinvasive, follicular thyroid carcinoma widely invasive, Hurthal cell tumors, Hurthal cell adenoma, Hurthal cell carcinoma, poorly differentiated thyroid carcinoma, anaplastic thyroid carcinoma, squamous cell carcinoma of the thyroid, and medullary thyroid carcinomas. Talking about the follicular neoplasms, females are affected more. Older age or with a peak age in 40 to 60 years of age are affected more. It happens rarely in children. It is associated with iodine deficiency and irradiation exposure and older age. Clinically, on radionuclide scan, usually these nodules are cold. They may arise from pre-existing adenoma. Don't they doesn't metastasize through lymphatics but does spread to lung, liver, bone, brain via blood vessels, and less than 5% ipsilateral lymphadenopathy has been noted. On ultrasound, a solid hypoechoic nodule with peripheral halo has been noted. Irregular or poorly defined margins may be suggestive of carcinoma. Grossly, these tumors are tan to brown, solid cut surface, and can have cystic changes and hemorrhage. They can be minimally invasive and widely invasive. When they are minimally invasive, they are in usually a single encapsulated nodular form with thickened and irregular capsule. And widely invasive has extensive permeation of capsule or no capsule. All capsule with adjacent tissue needs to be submitted for histological evaluation. Histologically, trabecular or solid pattern of follicles may be seen in microfollicular, normofollicular, or macrofollicular pattern. There is no nuclear feature of papillary thyroid carcinoma. To differentiate between follicular adenoma and follicular carcinoma, capsular invasion and vascular invasion are the main features. Capsular invasion and vascular invasion are seen in follicular carcinoma and not in follicular adenoma. These follicular neoplasms may have nuclear atypia, focal spindled areas, and mitotic figures. Usually, no necrosis is present and no squamous metaplasia, no samoma bodies are seen. Here in this image, I have shown follicular carcinoma, which is in which there is invasion of the capsule as noted by the arrow. In this micrograph, you can see vascular invasion in follicular carcinoma as depicted by the red arrows. Treatment of follicular neoplasms. If follicular cells are found on cytological testing, it is common to carry out hemithyroidectomy to distinguish between follicular adenoma and follicular carcinoma on histopathological examination, proceeding to completion thyroidectomy and postoperative radioiodine ablation where carcinoma is confirmed. This way, total thyroidectomy is not carried out unnecessarily. Do subscribe to the channel if you're liking my videos. Thank you.